Hello and a very warm welcome to today's ISNTD Connect in partnership with the Global Schistosomiasis Alliance. My name is Marianne Comperat. I'm speaking from the International Society for Neglected Tropical Diseases. Very warm welcome to our weekly sessions, ISNTD Connect, where we look at all things tropical diseases. It's my pleasure today to welcome our speakers. On my screen, we will be hearing today from Dr. Torres Vitolas. Hello, Carlos. Thank you for joining us.
Good morning. Good afternoon, everybody.
Hi. Carlos, you are Senior Advisor for Research and Innovation with Unlimit Health. It's really wonderful to have you here today. And I'm delighted to welcome as well Dr. Geordie Woods. Hi, Geordie.
Good morning. Good afternoon, everybody.
Hello, you're Director for Behaviour and WASH and Neglected Tropical Diseases at Sightsavers. We would, under normal circumstances, also have our third speaker with us, Ulfat Amour, who's Assistant Qualitative Researcher at the Public Health Laboratory-Ivo de Carneri, based in Zanzibar. But unfortunately, due to a power outage where Ulfat Amour is based, she will not be able to join live for the time being at least, but we remain hopeful that she will be at some point able to join. We do still have a wonderful recorded presentation that's just come through. And so today, our three speakers will be really shining the spotlight on behavior change interventions for schistosomiasis control. Some very ambitious targets at WHO when it comes to schistosomiasis, as I'm sure you know, to reach elimination by 2030, with interventions as complementary and diverse as treatments, also environmental interventions, and then this is a very important, strongly recommended component of behavioral interventions. But what do we mean by that? Do we know enough about them? Are there still knowledge and implementation gaps when it comes to behavior change interventions? Lots of questions that we will seek to answer over the next 90 minutes. Some fantastic examples drawn from the field with Ulfat Amour's presentation and illustration of what can be done. And finally, some very interesting, innovative tools adding to the toolkit of behavior change, particularly in WASH for schistosomiasis. So quite a packed session ahead of us, really fascinating insights, and also I take this opportunity to welcome very warmly all of those who have joined us live. Lovely to see you here with us. If you can, when you have a moment, please don't hesitate to jump in the chat. Let us know where you're connecting from, your country, your organization, and any questions, any comments you may have for our speakers. As the next hour and a half unfolds, please do put them in the chat, ready for our discussion a bit later after our three initial presentations. So without any further delay, Carlos, I'm delighted to hand over the floor to you for your first presentation. You'll be talking to us a little bit more about a scoping review of research on behavior change. Carlos, over to you. Thank you for being here.
Thank you, Marianne, and thank you, everybody, for joining us today. She said I'm going to talk about the systematic review we conducted in coordination with the Global Schistosomiasis Alliance. This systematic review examined behavior change interventions for schistosomiasis control elimination in low and middle income countries. I'm just going to share the link to the actual paper on the chat. So even if anybody who wants to look at the details, you can access the paper later on. So let's start with the background. I think Marianne already said something about it. As you are all aware, the 2021-2030 roadmap for NTDs is already in the section for schistosomiasis. Is already talking about the importance of conducting behavioral interventions for communities, schools, and health facilities, as well as about the importance of raising awareness among the general public. and also the 2021 WHO guidelines for the control and elimination of schistosomiasis, in its recommendations, also talks about the importance of including behavioral change interventions alongside treatments, as Marianne stated. Now, for us, the group that was working on the systematic review, instead of looking at individual risk behaviors such as bathing or latrine use, etc., in order to understand what's the state of the sector, we consider it important to look at not the specific individual risk practices, but look at the role that human behavior fulfills in the transmission cycles of schistosomiasis. In transmission, we were looking, for example, at the different practices that were connected with the release of the schistosome X into the environment. So we're talking about urination in surface water, defecation in surface water, latrine use, maintenance and cleaning of latrines, etc. In terms of exposure, we were looking at those human practices that expose individuals to natural water sources so that the cell carrier could enter the human body. And that also talks about a variety of human practices, which basically talking about water contact activities, but also the use of protective gear when interacting with water, for example. And of course, in the context of schistosomiasis and elimination, control and elimination, nowadays we're talking about treatment activities. We're talking about to what extent individuals who were consuming praziquantel, because that action actually interrupts the transmission cycle of schistosomiasis insofar as it does not allow the schistosomes reaching adulthood or does not allow for the eggs to be released in the environment. So it was a very comprehensive understanding of risk behavior, and the idea was to look at behavior change interventions that were trying to tackle these three different components, assuming that behavior change interventions refer to those concerted and planned activities that were aiming to modify people's practices. Now, in terms of the systematic review, I'm not going to go through all the details, but basically we look at all publications that were talking about behavior change interventions, explicitly stating that they wanted to control or eliminate schistosomiasis in low and middle income countries that were released prior June 2021. There were no restrictions according to the type of intervention or audience or evaluation design, because we wanted to have a comprehensive look at the state of the sector with regards to this subject. And after an extensive review of over 5,000 different references, we ended up looking at 32 papers, which were discussing actually 31 projects. So in principle, we're talking about really 31 projects. Some of them used, we worked with direct outcome measures, such as basically behavioral indicators of change in terms of actual practices, but also indirect indicators in terms of, for example, presence of infrastructure or treatment, the demand of treatment in the community, etc. Where the evidence came from, we're talking about mostly sub-Saharan Africa, as you can see in the map on your screens. And outside Africa, the main source of information was China, actually. So it tells us more or less that where the evidence is coming from. So the extent to which we can generalize our findings is affected by the geographical distribution of the evidence. Now, a very quick look at some key messages coming from the results. The first one was that of the 31 projects that we examined, around half of them were trying to tackle more than one risk behavior at the same time, which was quite surprising. We were expecting a bit more of the segregated approach to these risk practices, but many projects were trying to tackle more than one behavior at the same time. And actually 5 of them were trying to tackle all 3 forms of risk behavior simultaneously, which was quite ambitious. In terms of some kind of salient characteristics of the methodology used by the studies, one of the main salient ones was that 3/4 of all the projects never explicitly stated what was the rationale for their interventions. They were mostly reporting on whether what they did or not worked, but they didn't explain why they expected that intervention to work. There was very limited use of theoretical frameworks or even logical frameworks to explain the interventions. Second thing is that one of the challenges we faced is that even though some projects were tackling the same type of risk behavior, the use of indicators was not standardized. So sometimes we could find projects that were trying to address the same issue, but measuring outcomes in different ways. So some were talking about latrine use, but some others were talking about open defecation, which is not exactly the same insofar as it addresses also defecation and urination in public spaces. and others were talking about explicitly about urination or defecation in water sources. So they all concern transmission, but they were measuring the success in dealing with transmission in different ways. And two additional points observed was that half of the papers rely exclusively on self-reported measures, which after education can generate some bias because people are already aware of what expected positive outcome projects may like to see after intervention. And secondly, 1/3 of the projects didn't have a comparison or control groups to assess the effectiveness of their activities. Because of the lack of theoretical frameworks, we made a detailed analysis of the different strategies all the different projects conducted, and we could distinguish different intervention models. I'm going to talk about three because these were the ones for which we had most of the evidence, and the most popular one was the health education intervention, or the health education approach to behavioral change. As you can see on your screen, the main rationale for this project, for this type of projects, is that if we provide information and enhance people's knowledge, behavioral change will happen. And typically, they provide information about the transmission cycle, about what preventive measures should be adopted, the consequences of having the disease, either in health terms or in socioeconomic terms, about the severity of the consequences and the benefits of following the advice recommended by the projects. Some interventions also outline explicitly what were the pros and cons of adopting the recommended measures, and some mobilized teachers and authorities in order to deliver the message. Some interventions targeting children you also use entertaining ways of delivering the message, such as game, plays, or comics. And in addition, some projects also provided rewards and incentives or environmental cues to action, such as posters or information printed in bags or plates or washing stations, so that would remind people what they should be doing in terms of their safe practices. In terms of what were the outcomes observed from this type of interventions, as you can see on the left of your screen, most of these projects were concerned with exposure and treatment uptake rather than transmission, but information was different for exposure as compared to treatment uptake. Exposure, the information provided was mostly mixed results or negative results rather than positive ones, whereas in the case of treatment uptake, actually most of the information was positive, indicating that these interventions managed to enhance treatment uptake among beneficiaries. And these contrasting results can be more or less associated with the key challenges observed among health education interventions. These interventions had challenges in terms of dealing with some individual level issues, such as economic obligations. If one is a rice farmer or a fish folk, you are not going to be able to adopt that information because you have economic obligation to perform. If the domestic duties one has imply bathing children, washing clothes, washing the dishes, your domestic duties, or again, limit your capacity to adopt the information you're receiving. At the interpersonal level, there are domestic power imbalances, particularly for projects targeting children. For example, if children receive information about safety, preventive measures they should adopt, what is their capacity to tell their parents who have not been targeted by intervention to say, I'm not going to fetch water from this part of the river or from this stream, or I'm not going to wash these things in the river because it's not safe. So this capacity to negotiate what their domestic obligations are is an interpersonal issue that health education interventions find difficult to deal with, in addition to social pressure and social influence. At the community level, certainly infrastructure, because health education interventions do not provide infrastructure in sanitation or water provision, then again, the capacity to deal with those material restrictions is limited when we only have no information. And at a societal level, there are sociocultural traditions, the natural environment. If I live in a community with plenty of rivers and streams and it's floodable, again, with just information, my capacity to deal with those forms of exposure is limited. And state-society relations, if I don't trust the state and I don't trust the Ministry of Health or don't trust external actors, my capacity to, my inclination to believe the information I receive can be limited. And with regards to these four sets of challenges, we could see, for example, that in terms of treatment uptake, in the context of mass drug administration activities, There is a very limited time demand of people on beneficiaries to receive Praziquantel. We're talking about activities that are very short term, so they don't interrupt the domestic duties or economic duties too much. We're talking about treatment that is provided for free, so there is no need for investment. Most of the resources for the treatment provision are either provided by the Ministry of Health with some support from the communities. So is that there is no need for major investments or infrastructure provision in order to implement that action. And so in this case, we can see that depending on the type of behavior one education intervention is targeting, they face different types of challenges according to the structural issues at play. The second intervention model we observed was something that we call the social environmental approach, the social environmental model. In this case, the rationale is different. The idea is that if we reach out to the entire community, parents, authorities, children, and we also convince the community as a whole to align their formal rules, their associations, their leadership with the recommendations provided by intervention, then at the formal level, at the formal level, the social structure will reinforce the adoption of safe behavior. There is a type on the slide. Actually, we worked with 7 projects associated to this approach instead of 5. And in this approach, they also provided information, the same type of information that health education provided, but they also did a lot of community-based planning activities. So communities as a whole assess the situation of the communities, they outline solutions, they establish goals, they outline what are the measures they would like to adopt, and they committed publicly to achieve those goals. They set up their own monitoring tools, and sometimes they provided also rules in terms of how this will be implemented and monitored at the community level. One key characteristic of these approaches is that they try to do both information provision as well as planning and monitoring in a participatory way, rather than delivering messages with materials or lectures or through a different type of information delivery platforms. The idea is that community will interact with each other jointly all the time so that they could exchange information, learn from each other, and they will come up with their own solutions, their own ideas, and their own understandings of disease transmission. With an idea that will enable the community members themselves to believe that they can implement change, that they will enhance their self-efficacy in the process of doing this kind of approach. In addition to that, some of these projects provided infrastructure investments with local labor, and also ensure that associations will broaden their membership, they will establish new leaderships, and sometimes they will develop new associations in order to implement the intervention. In this case, as I said, we work with 7 projects, so information is a bit limited. The most clear trend, even though it's still a bit unclear, is that the projects that work on transmission, they tended to report positive changes, and the only one that reported mixed outcomes of the limitation they had was that they didn't provide infrastructure investments. So the most positive trend for social environmental interventions were concerned with transmission, with the prevention of transmission risk behavior when infrastructure was provided. And that speaks again with the challenges associated with this approach, talking about, again, economic obligations, domestic obligations. But as I said, infrastructure, if there is no support for infrastructure, is very limited to what community members can do. Because, and that's the other point, community resources the state of community resources is essential to implement community-based interventions. Insofar as for schistosomiasis, we're talking about a disease of poverty. So we're dealing with poor communities. If we want to mobilize community resources to prevent the transmission of schistosomiasis, we need to be aware that because these are poor communities, they have limited material resources, and sometimes they have limited human resources in terms of time availability for labor investments, as well as technical capacity to implement health or education interventions. Also, because we're relying on community structures, issues with regards to governance, the legitimacy of leadership, the strength of local associations, how wide or narrow membership for certain associations are, can affect how these interventions work or successful they might be. And then at the society level, again, sociocultural traditions, the state of relationships between the community structures and the government in general or public agencies. The third approach that we could also highlight was infrastructure investments, which we call the physical environmental approach. Basically, the idea is that if there are physical developments, people will adopt a new technology, they will adopt the new infrastructure, and then they will adopt safe behavior. And there is a typo here. Actually, we work with 5 projects rather than 7. In terms of results, there is limited information because we were all working only with 5, but in general, they were trying to control water contact behavior, and the information the outcomes obtained were mostly mixed. And there are key challenges that affected this set of outcomes. The first one is wealth. Because we're talking about infrastructure development, sometimes people had to pay for using the service, and of course, having the currency all the time in order to use these services all the time differ according to the wealth of the persons in charge. Watch infrastructure in terms of depending on how much need there is for additional infrastructure or not, the level of investment could be sufficient or insufficient. And one key point concerned the issue of public infrastructure. So, for example, if there is a community that provides latrines to every single household, then the question is, what happens when people go to the field? What happens when people go to the rivers? What happens when people travel along the road and go to walk around many different areas of the village where there are no latrines because every single latrine is just mostly private. So there is an issue about private investment in infrastructure as well as public investment in infrastructure. And that's conditioned as well according to the size of the community and how dispersed the population is in a community. And then in addition, we have again sociocultural traditions, natural environment, and because we're talking about infrastructure investment, the relationship between public agencies mobilizing that investment and the relationship they have with the communities may affect how well received or not these approaches are. So as we could see, basically, this review helped us to understand the great variety of challenges that are affecting all these different intervention approaches. And there is one that that cuts across every single layer, which is time. Or most of the papers that we reviewed were discussing that it's very difficult to understand the effectiveness of our approach because we're talking about short-term projects and behavior change usually needs to be sustained over time. So take-home messages from this. The first one is we need more research. As I said, there are certain methodological limitations in the evidence available at hand. So ideally, more quality research is needed. Secondly, if anybody wants to produce a new project or intervention, we need interventions and papers that outline what's the rationale of the intervention, that use theoretical frameworks and hypothesize why the specific intervention components are expected to have some change, generate some changes in behavior. And that they outline what are the specific type of behaviors they are targeting. As I said, try to target all 3 at the same time could be quite ambitious, because each of them already contain quite a variety of risk practices. So a more clear and detailed understanding of risk practices will be recommended. Now, in terms of interventions themselves, in terms of education and information, as I said, what we learned is that there is limited evidence that information provision can prompt behavior change when there are structural barriers, as in the case of MDAs, because of the resources and the limited time investments required to prevent the behavior, health education interventions could be more successful, apparently. But one point that was clear was that almost every single project that reported positive outcomes, they all had an educational component. So even though the structural barriers may prevent the effectiveness of health education to generate change, it seems that education is still essential to foster change anyway. Fourth message is that risk behavior is socially embedded. That means that, as I said, the capacity for children to adopt safe practices is interconnected with the relationship with their parents. The same thing in terms of gender relations and domestic duties, for example. Sometimes the way we understand the relationship with our authorities and the leadership or the associations that we have in our community. So community-based activities could be quite useful in this case when we have these kinds of pressures. However, as I said, the context matters quite a lot for socio-environmental approaches in terms of what are the community resources, what are the community structures, how legitimate they are, how many resources they have at their disposal, can affect the success of these intervention strategies. In terms of infrastructure, as you have perceived, Infrastructure is a major barrier for every single intervention strategy. It's clear that we need more material support in order to enable the adoption of safe practices, not only for sanitation, but also for water contact behavior. In summary, if anything can be summarized in 2 lines, this will be a recommendation from the review. We need integrated approaches. It seems clear that information on its own may not be enough, community organization on its own may not be enough, and infrastructure on its own is unlikely to be enough as well. So it would be ideal to have more integrated approaches working on in the sector, and that it would be also recommended that all of them not only think about the success of the project, but how the success can be maintained over time. What sustainability measures can be adopted in order to foster a long-term and sustainable change. That's all from my side. Thank you very much.
Thank you very much, Carlos, and a big thank you also to all the co-authors on this huge body of work, as many of which are on the call, Anouk Guvras and also Willem Zadnorgic, Suzanne Trinikins. Thank you so much. It's given how strongly behavior change is recommended as part of schistosomiasis control. It's been very useful to understand and order what the evidence says and which one exists, and also the many gaps that remain. So thank you so much for that. And so just to take us now in a bit more concrete terms in field, I'm going to play the recording of Dr. Ulfat Amour Mohammed's presentation. Unfortunately, she's still not been able to join us live, but in the meantime, let's hear this presentation, and hopefully perhaps there'll be a chance for a few minutes to see her live towards the end of the call. But thank you, Carlos, and now over to Ulfat Amour.
Good afternoon, ladies and gentlemen. My name is Ulfat Amour Mohammed. I would like to present about behavior change intervention for schistosomiasis elimination in Zanzibar. So the goal of this guideline is to provide evidence-based recommendation to countries in their efforts to accomplish schistosomiasis mobility, control, and elimination as a public health problems, and to move forwards interruption of transmission. The recommendations contained will help countries to implement national schistosomiasis control and elimination program, and support efforts to verify the interruption of transmission. So you can see here the data of the children, school children from 9 to 12 years old. From 2012 up to 2021, there is like up and down, and the kichocho was high also for the students. And here it's for the community. You can see 2011 up to 2021. Okay. And sometimes it's happening when some Shahia's children, they have many kichochos, but in the community they have very few people they have kichocho. So it's just like that. And Ministry of Health, they provide MDA, mass drug administration, to the community, children from 5 years old, starting from children from 5 years old up to elder people, and this is done from the both island, I mean Pemba and Unguja. But still, children likes using water, and not only children, many peoples, even after they getting drugs, still they have some activities that they going back to the river. There are a lot of activities people like to do, like farming, just swimming, washing, and even the irrigation, even the planting. So many people's also farming in the river, as you can see here. So for behavior change intervention, we have school-based classroom education components. We was having school-based Kichocho safe play components, and also we was having community laundry platform. So teacher, there was lack of knowledge and resources for teaching students about Kichocho. It was dedicated that classroom education component was needed. And also the life circles was assist children to not peeing in the river. It was dedicated that we needed to design and promote a community urinals for children near the streams or ponds identified as a hotspot. It was dedicated also that the education everyone about the risk of girls to get kichocho was important across all intervention components, because they were thinking that only men can get kichocho because I think women cannot see their pee. So, but many it's easy to see if there is a pee or blood, there is blood on when they urinate. So in the teacher training, we developed a life cycle, and this was created by teachers, and this shows the simple life cycles from the beginning, that we just assume that someone is going to the river and pee. On his feet there is blood, and there is on the blood there is some eggs of kichocho coming from the pee, and then when it's just touch the water, hatch, and then this kind of things coming from the eggs, and it stay for the snail, find the snail and stay there for some times, and then you and me, when you're going to the river, you may get kichocho, and schistosomiasis can stay in anywhere on your body. Kichocho is a Schistosomiasis. And also we create a snail board which is showing the different snails, but the one we need them to understand is snail of Kichocho, which is very tiny here. So in the river we have many kind of snails, but the one we are talking about is very small, and we want children to identify themselves. And also we create teaching tools, as you can see here in the picture. And also we make a picture of a bloody fluke, which is very many students like scared about. And also community say, it's not good things to have this one. So when we're going to the community for the Kichocho Day, we have all of this, and also we use this for classroom as a teaching tools. You can see here, children are so happy, and like children likes playing when they like learning when they playing, so it's like very good for them listening. They stay very quiet, as you can see on the picture here. And also in this Kichocho Day, this is a special day. We having drama, skipping rope, tug of war, a lot of games that can in these games there is message inside that children get, and other people, because also we invite community members, community leaders. They coming here and see what's going on. So in their activity, children, they explain about Kichocho, and also they asking themselves like 5 questions for them. If the loose team, they're going to answer those questions, so the message is remaining with them end of the day. So some children also drawing themselves the picture, and they wanted to just to show the other students, like this is, like this student was showing the picture of urine have Kichocho, and this one doesn't have Kichocho, so it's like symptoms. She can, later on she explained the symptoms of Kichocho. Actually, this day is more fun. Children's like playing. There is like sacro, skipping rope, tug of war, a lot of things going on there. And as you can see, children doesn't like to stay like attentive, but here they're listening very well. So as I was explained, in all of our game there is message about Kichocho, and here as you can see there is a tug of war, but on the middle we like drawing and we pretend like there is a river. So the team who's falling into the river, they're going to answer the 5 questions. What is Kichocho? What is in the river that can cause Kichocho? What are the signs and symptoms of Kichocho? How do you treat Kichocho? How do you prevent getting Kichocho? Just like that. And washing laundry was identified as a major risk behavior. So it was dedicated and decided that a safe laundry platform was needed so children did not have to go to the contaminated water to wash. The behavioral team is here today to prevent. So it was doing like this. As you can see here, children's washing into the river, their feet, it's in the river, even this one. So here is the washing platform that we construct, and it's designed by, you can use bar soap or you can use powder, and there is like sitting place. You can sit here without any problem. And for this, we're using cement and the bricks, and also there is like pit water going down to this pit. And here it is. As you can see, people were so happy to have this one, and most of the time when we're going to field, we just pass by and check if it's working. And when we build the community, then we just provide the materials and the fundi and the other things they provide themselves as a community. Okay, so this is a picture of washing. The people was so happy and used. So when we go there, we also asking the community members how they like it, and they say the clothes do not get muddy, they get place to sit. They can use bar or powder soap, use of basin or cement to scrub, and also clothes and the convenient, and the water is clean, and also they cannot get kitchen. You know, one children was talking about a young girl from Moira School, Unguja, when we was interview her, and she said, I don't play in the river because I might get kichocho. Sometimes we have to wash clothes and dishes to do domestic things in the river because there were water problem in our area. So because there is still problem of not having water, children sometimes they should go to the river, but at least they know what's going on there. There is kichocho, so they may take water and stay outside of the river and washing. So in the river, we attach some signs that show the people that there is kichocho in the river, so they have to stay away and also not pee in the river, as we know that if you have schistosomiasis, I mean kichocho is schistosomiasis, guys. So if you have kichocho, you have to if you have kichocho and going to pee in the river, you may transmit that river, and many people who's coming to use that river, they may get kichocho. So here is the message. To go home with behavior change communication is very important. It's important supplementary intervention to mass drug administration for control and elimination. Important intervention strategy components once MDA is stopped, recommended and appreciated by the community, needs to be applied with high coverage and outreach. And behavior change requires knowledge, but also access to the alternatives such as clean water and sanitation. Thank you so much for your attention. And I would like to say thank you. Thank you so much for listening, and I would like to bring it back to the owner of this.
A big thank you to Ulfat Amour. If you are watching this perhaps through the recording, or maybe you've been able to connect for a few seconds as an attendee, a huge thank you. What a lovely presentation with lots of really nice illustrations of what's been mentioned, included in the literature, whether that be examples of the visual materials being referred to, but also participatory sessions or tailored messaging, even school interventions and teacher toolkits. So lots of really concrete examples to show what is being spoken about in the literature, in many of the more policy or implementation oriented documents. So thank you, Ulfat Amour. And when it comes to behavior change interventions in schistosomiasis, the one collaborative overlap in terms of sectors and fields that really springs to mind is that between the WASH sector and the NTD sector. So for the third part of these presentations, we're really looking forward to hearing about the second version, the second iteration of a WASH and NTD toolkit, with again some very practical recommendations on how to best work together and implement behavior change interventions in endemic areas. So without any further delay, I'd love to hand the floor over to our third speaker, Geordie Woods. And while you reconnect, I'll just put your slides up, Geordie. It's yours.
Awesome. Thanks, everybody, and thank you to both Carlos and Ulfat for the fantastic presentations. It's a tough audience to follow. So I'm going to this is a little bit of a teaser of something to come. What I'm presenting is a quick guide to social and behavior change in NTD programs. And as Marianne actually she referenced the Washington NTD toolkit, the WHO Collaborating Together toolkit. And actually, the second version of that, I'll just move on to the next slide here. And, oh, by the way, I'm also presenting this piece of work and this bit on behalf of the WASH working group within the NNN, the Neglected Tropical Disease NGO network. So this is just me presenting on behalf of everybody else, although I've certainly been a part of all of it. So many of you on this webinar may be familiar with the WASH and Health Working Together Toolkit. The second edition was actually released last year, and it came with a couple of updates to the original one, including a bit more on some of the planning tools and specifically around a lot of the tools of how to budget for and plan for. But one of the big things that was highlighted in both editions that was sort of still missing was a bit more of a deep dive into, okay, great, how do we do some of these behavior change programs? From both of the previous presentations, it's really clear that social and behavior change interventions and programming is likely the next frontier of NTD programs. As we get closer and closer to elimination or control, the really hard parts are going to be the social and behavioral elements of these programs in terms of either whether it's uptake of key drugs to marginalized populations, or it's really just sort of tackling some of the tough behaviors around infrastructure and hygiene and water and sanitation habits. So that kind of leads us to the quick guide. And so I guess why a quick guide? So this quick guide is intended to be a bit of a compendium to the new updated second edition of the WASH NTD's toolkit. And really what the quick guide is I guess we've not originally started as a large toolkit. And I think that maybe some folks maybe on this call would recognize that the world needs another toolkit, like they need perhaps more poverty. I say that in jest, but I think we really wanted to find something that was really practical, because there are actually quite a lot of resources out there for really excellent social and behavior change interventions and programming, and we wanted to make and develop something that was accessible and quick, but also something that was really specific to the needs of the NTD's community. So really honing in on what are the behavior change needs for NTDs specifically, and how can we share some of those lessons across programs, similar to this webinar of the systematic review from Carlos and Unlimit Health, and some of the really specific interventions that are happening. So part of this quick guide is to really just make it as accessible as possible, and also to be a platform to help share some of the existing knowledge. So along with this quick guide, there will be a number of case studies that the WASH Working Group has been collecting, and that will be kind of released iteratively along the course, along with this quick guide. But really, I think that the thing that we really wanted to highlight in this quick guide is that it's really trying to provide a minimum set of actions or recommendations for programs to, as Carlos highlighted, that the best approach is going to be an integrated approach. So really finding what do you really need to at least target when you're looking at trying to address behavior change for NT outcomes. And then the other sort of programmatic piece and practical piece to this guide is really helping to support programs to find the justification for resourcing of social behavior change within programs. Oftentimes those of us that are in this sort of realm often find that the resources available to do these types of interventions that we've been talking about in this webinar are oftentimes hard to come by, or oftentimes maybe the first to get cut, because it's not as cut and dry as, say, providing surgeries or providing drugs. So I think what we're really hoping to do with this quick guide is really help programs at all levels really justify why they need the resources to do quality social behavior change, which is oftentimes not always the most inexpensive thing to do. I will say that what this guide does not provide is a definitive set of recommended interventions. It's not if you are going to do behavior change for trachoma or for schistosomiasis, here are the 4 interventions that you need to do, because that just it's sort of counterintuitive to everything that we know about contextual driven social behavior change programming. So, and again, I won't sort of preach to the choir, certainly probably not on this webinar, but again, knowledge is not enough. And back to kind of the findings from the systematic review, that sort of knowledge generation and this sort of one-way information out gets us to a certain point, but it doesn't really get us to the sort of the fundamentals of really changing the drivers of behaviors. What's underneath those behaviors? Why are people doing them? So it's most often not going to be just because someone didn't know about not peeing in a river, for example. So really the quick guide is really sort of trying to help hone in on understanding how to prioritize what are the key behaviors that we need to target, who are the audiences we need to target, and then I can't stress enough, this sort of that last piece is really, I think, the guide provides sort of a systematic way for each sort of section to justify the resources that you would need to allocate in order to provide, to design, develop, and implement a social behavior change aspect to a program. So really helping to provide the justifications and elements needed within a program that need to be budgeted for. So, now to get theoretical, and of course, no good presentation is without a good diagram, but sort of similar to the approach that Unlimit Health took in the systematic review. I think one of the really key things that this quick guide is sort of basing a starting point on is really sort of using a conceptual framework model of transmission for a starting point to really build a program out. And again, as Carlos had mentioned in his presentation of there's all these different types of behaviors. There's transmission behaviors, there's exposure behaviors, there's uptake of medicine or care behaviors, and there's a lot of behaviors in there. And I think oftentimes, these are complex diseases, but certainly when we're talking about schistosomiasis, we really have to be really clear about what are the specific behaviors that we're targeting, and that can oftentimes get muddled. And the further you get down into a program, sometimes that starts to cross over, and we lose track of what are the things we're really trying to do. So we've taken it a step back and provided sort of a conceptual framework model for each of the diseases. And so for all of the diseases in the toolkit, we are offering this type of model. So you'll see sort of in the middle, the individual level, the transmission pathway with clear transmission behaviors on the left side, and then kind of moving through as the vector and the pathogen goes to what are the exposure behaviors. And then in the outer circles, sort of looking at those who are familiar with behavioral frameworks, the socio-behavior framework, looking at sort of WASH and environmental health services on the outside of that, and then on the far exterior, the societal sort of stigmatization, exclusion from services. So these are all the different factors that are going to build into our behavior change model. And at the end of the day, what are the behaviors we're really trying to target? So this is sort of, again, the link to the WHO WASH and health working together piece. There's this wonderful tool in that toolkit, which is really kind of outlines all of the health outcomes, behaviors for NTDs. So sanitation, hygiene, water, treatment care, and other behaviors for all of the 21 NTDs. And this on the left is just sort of a model for soil transmitted helminths. And again, what we're really looking at is helping a program to really just decide what are the transmission behaviors that we're going to focus on, what are the exposure behaviors with regards to that. And so, this can get complex, and we're really trying to offer a way to really just help simplify and target as much as possible. So that's sort of the intro to the guide and the kind of the background and how it's set up. And then there are really 4 core sections, although there are 6 sections to the tool. There are 4 core sections, and each of those sections are split up into really, I have to say, really like a page and a half at the top, at the very most. And it sort of provides an overview of what of that sort of step or section is. Provides a lot of guidance and planning tools. And so this is the case where we've really tried to bring in and reference what we felt are some of the most useful and practical guides and planning tools that are out there. So some refers back to the ISNTD toolkit, and some refers to other, lots of other organizations' tools that are out there available. And then the next part is really sort of, if you're going to be planning for a social behavior change intervention, what are the minimum actions that you really need to do in this particular section to be successful, and then the considerations, and then the further resources and links. So, each section kind of goes through sort of, investigate really talks about, figuring out what those behaviors are, what are the drivers, and what are the behaviors you're going to focus on. And then the second piece is really driving down, okay, what can we reasonably do in a program given our financial constraints, our logistical constraints, and everything that you would do in sort of planning, you want to focus down on, like, what are the interventions? And then the third piece is the design that, in terms of really, I think this is an element that gets left out of the behavior change stuff. We have all the information and we're just going to push it out there, but really, you know, designing that in the context of our audience and in the context of something that looks good. And then the last piece is that learning piece in terms of, you know, how are we monitoring it? How are we iterating, making sure that the intervention is learning from itself. And then I've put the star on the right, but there are a couple of little subsections at the very end that are just really specific. And so we've got a list of sample indicators, and we're also offering some really specific frameworks. As you know, Carlos had mentioned in his presentations, that there's oftentimes really a lack of kind of pinning a social behavior change intervention to a theoretical framework or to a theory of change. So we're offering a number of frameworks there, and then some implementation tools. And when I say implementation tools, this is sort of M&E specific in terms of, you know, specific guides for qualitative research, specific guides for evaluating types of behavioral change interventions. Because these are complex interventions, it's not quite as simple as just running a randomized control trial oftentimes. So really helping to point direction in some of the really excellent tools out there for doing research and understanding how we're doing in behavior change interventions. So, and then after that, the very, very end of the tool, of this quick guide, I should say, I keep calling it a toolkit, is disease-specific tips and tricks. And so far, we've got, I think, 6 or 7 diseases in there. We've tried to really give a range of the different NTDs. So not just, you know, the PC NTDs, but also, you know, we've got rabies, we've got dengue. We're trying to give a good range of all the NTDs. And ultimately, we'd like to have this sort of subsection for all of the NTDs, but we want to get this out to folks. So we're starting here, and each of those really has some key messages specific to that disease. So if we're talking about schistosomiasis, you know, where do you really want to target social behavior change interventions for a schisto intervention, for example? So if, for example, an area that's, you know, above 50%, really high endemicity and prevalence. So really just where do you want to target? What are the considerations you want to focus on? Do you want to consider some community-based targeting, like considering, you know, where are the water points that we're really talking about, and you know, specific methods for determining where, you know, which water source you're focusing on. So each of those diseases has this very sort of this cheat sheet of like of specific tips and tricks for the designing the social behavior change. And you know, that as guidance comes out, those will also be adapted based on, you know, relevant research and guidance. So that is my very, very quick whistle-stop tour of this quick guide. So I know there may be questions, but maybe like just also to end, but this is not yet out. We're still in the copy editing phase and designing it so it looks nice. It will be ready for electronic sharing with everybody probably in the next month and a half or so. And then we're hoping to have a hard launch this September at the annual NNN conference. So I will hand back over to ISNTD, but thank you very much for having me, and thank you to the other 2 presenters.
Thank you very much, Geordie. That was an amazing, really useful, exciting look behind the scenes of this guide. Nearly ready for the launch. We'll all be keeping an eye open for that. Thank you so much. And in fact, thank you to our 3 presenters, and beyond those, also the teams, the co-authors, everyone at the Public Health Laboratory-Ivo de Carneri, a wonderful collaborative team there across surveillance all the way to these public health interventions. So a really fascinating, extremely enriching session. Thank you so much. We have a few minutes for a discussion, for any questions from the audience, or maybe even just comments or something you may want to share about your own work, your own projects and experiences. There's a lot of resources as well that have been shared in the chat, whether that be teacher toolkits or references to papers that have been mentioned. So please don't forget to go and have a look in the chat. Some questions are coming through already. Before we turn to those, just a very quick point that permeated some of the presentations. It kind of stems from this notion of what gets measured gets done. And just thinking for a moment, picking up some of the things you mentioned, Carlos, also came through in your presentation, Geordie, about indicators. You said very varied indicators, Carlos, maybe some that weren't immediately comparable, or what could be done, particularly now bringing in a completely different sector, what could be done or what can partners on this call as well do to perhaps homogenize those indicators or go towards a set of measurables that can unify a lot of these behavior change efforts?
Well, difficult to say insofar as nobody can control really what everybody does with regards to how to conduct the M&E activities. However, I guess that one key point here would be to say what Geordie and their team are saying, which is that there are plenty of resources already available on the web, not only for WASH, but for all types of behavior change interventions. And actually, one of the things I will encourage everybody to do is to look at behavior change interventions for other NTDs, rather than just focus on schistosomiasis. There is plenty of literature everywhere, particularly for transmission. The WASH sector has plenty of community-based interventions for hygiene and sanitation. Look at those resources and the most used ones in the sector, and try not to say copy and paste, but try to adapt to the greatest extent possible to your own interventions, tailor them to your own circumstances, and see how we can ensure that our interventions can speak to the other ones, not only in the schisto sector, but also in the NTD sector. So using the same kind of common resources, I think that there's a possibility to start developing a more standardized approach. And hopefully that will be the case when the toolkit comes out. I hope that everybody will use it and people will know where the resources are.
That's some great advice. Thank you, Carlos. Geordie, did you want to add to this?
Yeah, I mean, I think I would just sort of second what Carlos is saying in terms of there are, oftentimes I think we like to recreate the wheel in specific programs, and there is really a lot of information available. And that's one thing I hope that the Quick Guide can do is help to maybe make doing, a web search a little bit less daunting and point to some really specific interventions. I think that's what the case studies are hoping to bring to this, is really sort of highlighting some great case studies from all over the planet in NTDs, and not just Schisto, but all of the different NTDs of what's working and what's not working, and then pointing to some specific tools in terms of monitoring and evaluating. I think that oftentimes we don't recognize the complexity of behavioral intervention monitoring, and we try and simplify it into sort of a bucket of worked and didn't work versus sort of some of these more complex outcomes.
Thank you. A couple questions have come into the chat in the meantime. Perhaps just going a little bit back to schisto intervention themselves. We have quite a varied audience, and so Anatol Miranda Biaruhanga was asking, so was the snail control in Zanzibar or Pemba? Was there an impact in schistosomiasis infection? And also a little bit related, a question from Eghi and Abulele, are there any practical recommendations for what communities can do when their only source of water is the site of schisto infection, particularly some of the very positive outcome that's come out of projects such as Schisto Break? Did you have any examples and insight into some of the successes around Pemba? I'm not sure who wants to go first. It's a shame Ulfat's not on the call as well, with some really wonderful insights straight hot off the press, straight from the field.
I'm afraid I have no context to add anything to this.
Well, we've had, to answer both your questions, we've had, as part of this Global Schistosomiasis Alliance partnership, we do have a lovely range of exactly these webinars looking at lots of different kinds of interventions, different kinds of successes from a range of regions across Africa. So please, by all means, I will put a link in the chat in the next few minutes, and we certainly highly encourage you to go and have a look at those. Just checking for any further questions. One from Anouk, who is asking, just wondering, since there's lots of discussion about integration of NTDs, is this possible with behavior change interventions? Do they need to be disease specific? And can social and behavior change interventions for more than one disease be implemented by one NTD team?
I can answer that fairly quickly, and others jump in. I think the quick answer is absolutely. They don't need to be specific to disease. The group working on the quick guide, I think, struggled a little bit. What is going to be most useful to NTD practitioners and teams, and we sort of decided to kind of focus in on diseases to make sure that we are, if you're targeting, programmatically a specific disease, that you're targeting the right behaviors. But as you know, lots of those behaviors overlap. Well, hand washing, for example, is, has many benefits well beyond just NTDs, and same with hygiene practices and other practices. So they can be integrated, and they can be integrated by other programs. But I think it's making sure that we're being really targeted about, kind of back to Carl's point, is what behavior are you looking at, and that behavior may translate across many different diseases, even beyond NTDs.
I would like to add something there with regards to integration. I think that, as Anouk said, there is lots of discussion about integrated NTDs, and basically it's a way to ensure cost effectiveness in different interventions. With behavior change, we have not observed an integrated approach to behavior change working with more than one entity at the same time so far, at least with schistosomiasis. However, there is one particular thing that I have noticed in the literature, not only behavior change, but generally speaking about knowledge and attitudes towards schistosomiasis, which is that integrated sounds fine in general in terms of cost effectiveness, but in terms of clarity of message, awareness, and understanding of the system's mission, it adds more challenges to the mix. In fieldwork activities, there is already, for instance, plenty of mixed up messages in terms of schistosomiasis transmission and representations of water, and how this is mixed up with the stomach problems, diarrhea, or stomach infections, right? So, for example, during my field experience, I've talked to children who are aware of schistosomiasis, and what they really end up interpreting the disease as a kind of waterborne disease. And they say, so what do? I no longer play in the water where the water is dirty. So this term of dirty water is very common in their narrative, because they say it's fine to play and swim where the water is clean, right? So because what do they, at least in particular for Mason, how do they connect it with schisto in terms of stomach problems? So, and that's when we're talking about mixing stomach infections with schisto. If we talk about 3 NTDs working at the same time, because the transmission cycle and the epidemiological factors are not entirely the same, even though some practices are aligned, the clarity of message should be well prepared in advance when they're doing this kind of interventions. So, target the practices, but be clear about how you explain them so that messages kind of do not get mixed up in the process.
I often wonder, actually, if right now on a different webinar in a completely different disease setting or field, if there are other public health colleagues who are wondering, well, who could we integrate with and when they're facing challenges in similar areas. And so I was wondering, WASH, of course, being almost the lingua franca between a lot of medical public health problems and the kind of bridging the route to community health. Are there other diseases or challenges in public health, sectors that you feel, kind of linking a bit to Anouk's question, but in terms of behavior change, we've heard it's not always that simple, but are there any partners that stand out or that you would like to see more involved in this space?
I think, this is sort of unrelated to the quick guide, but there is this idea of integration or multi-sector coordination, and sort of this gets to some of what the WASH and health and toolkit is talking about. But any of these problems are going to be supplemented by behavioral issues, but also by the infrastructure elements, the education pieces. So I think that it's beyond just sort of different diseases. I think it's also entirely other sectors. So the education sector, the finance sector, the water and sanitation sector, the health sector, and each of those bring their specific expertise to the table. I would just sort of really second what Carlos was saying. I think that part of the issue in this integration thing is, we know that avoiding specific water areas is good for Schisto, but that message can get really a little bit too specific, and then we try and translate it to other things, and that's where it gets all muddied up. And just if we're oftentimes you don't maybe even need to mention any disease if you're talking about a specific behavior, right? I think sometimes we get a little too disease specific, but I think you need to know really what you're targeting when and where.
Fantastic. A question here from Naomi Chindo. Hi, for the social environmental approach, you mentioned infrastructure. Would health facilities be one of these, and how can we achieve behavior change for health facilities in these settings? So maybe leveraging the role of health facilities more in behavior change programs. How? Sorry, Carlos.
Yeah, no, I was wondering in terms of what behavior will be changed within health facilities in particular. So it depends on what's the role of health facilities within human behavior. In this case, maybe if we're talking about treatment provision, they might play a role, but I guess that's part of a broader discussion in terms of how Schistosomiasis control is integrated into the public health system. But yeah, there might be a role there depending on how the intervention is structured and conceived within the health system there. And in terms of how achieving behavior change in health facilities, it depends on what particular behavior you want to target within health facilities. I cannot provide a specific example now, but I know that in the literature, there are different examples of how behavior change within health facilities have been promoted, particularly among health practitioners, for example, or people who are attending health facilities in terms of hand washing, sanitation practices within facilities, use of protective equipment within facilities, or even note taking or report taking. So again, I cannot provide an example specifically for Schistosomiasis, but depending on what behavior you have in mind, again, my recommendation is look at it not only from the Schisto perspective, look beyond and look at behavior change within health facilities and among health practitioners, and maybe there might be an answer or some kind of guideline there.
I'm not sure, Geordie, you wanted to add to that? So here at ISNTD, and I think some people on the call took part in some part or all of what we call the ISNTD Festival, which really brings together all things creative with tropical diseases. And one of the topics that permeated the discussions was both that there is not enough funding for communications around tropical diseases, and then others seem to think that or have experienced there's actually quite a lot of funds and resources available for creative approaches in public health in tropical diseases. In your experience, which one is it? I mean, there's never enough money, right? So that's the given. But is it a compelling case? are funders coming on board to support specifically behavior change interventions? Is this accelerating? Which way are the trends going?
That's a dangerous question to ask. My personal experience, anecdotally, I would say, I think there's definitely a larger awareness. I mean, the fact that you know, in some of these new, even WHO, specifically NTD, you know, roadmap guidelines that we're really starting to explicitly mention, you know, social and behavioral change interventions are going to be integral to elimination. That said, I'm not sure that, from my point of view, I've seen a major shift in, you know, people funding this kind of work to really put more resources behind these types of interventions. I think that there's definitely acknowledgement that they're critical. I haven't explicitly seen a large shift financially. I don't know.
Yeah, I will agree with Geordie. I haven't perceived any major shift in the sector with regards to that. And actually, there is actually more questions in regards to how much funding is available for that amount of treatment required with the new guidelines as compared to schisto control through behavior change. However, one thing I just want to specify on what you said, Marianne, with regards to communication, right? One thing is communication, another thing is behavior change. They are not necessarily the same. And we have to be quite clear with regards to communications in terms that it depends on what you want your communications to do. Do you want them to do behavior change, or you want to raise awareness? And depending on the scale and the particular scope of your intervention, then whatever you have at hand may not be enough, or it might be. There are certain sectors, for example, certain communities in which I have observed personally, there have been national radio campaigns and TV campaigns. There have been substantive investment in that. But in the end, when I talk to people, they have heard about it, but what they do, who do they believe? The TV, the radio, or the person that talk, you know, on a daily basis because it comes to the village to talk about public health programs or whatever. And what they say typically is that they rely mostly on face-to-face interactions rather than national radio campaigns and national TV campaigns. I'm not saying that that's the case everywhere. I'm saying that in some cases that's the case. And in those circumstances, for example, working on communication interventions, relying on frontline workers may be more cost-effective than investing in massive national radio campaigns with marketing people involved and executive producers involved, etc. So again, it depends on what do you want your communications to do and the particular circumstances in which you're working.
That's a really good point. Thank you, Carlos.
And maybe I'll just add maybe another plug for the toolkit, but that's one of the things that we're really trying to sort of focus in that quick guide is, I think, you know, to no fault of programmers, that oftentimes they haven't explicitly programmed for parts, all of the pieces that you need to develop a really well integrated social behavior change program. So in terms of really mapping out early on, what are the drivers in this community? What are the things that are going to touch on those touch points? And then, you know, moving on, like what, you know, based on what we know about that, what are the different, you know, piloted different types of designs, prototyping different things that could work. So there's all these elements or opportunities within our programming that we haven't budgeted funding for. So, but at the end of the day, we want this brilliant social behavior change campaign to pop out at the end, but we haven't budgeted or integrated all the elements that need to kind of get you there. So I think that hopefully we're trying to sort of, at least maybe on the back end, influence people putting in budgets at different parts of programs that would potentially maybe result in better social behavior change sort of programming.
Thank you, Geordie. That's a really good point, which kind of leads to our last question, and perhaps to bring all these discussions, tie them together. So, Carlos, you've mentioned that as part of the survey that different programs are working perhaps to slightly different targets and indicators, and there remain some gaps in this behavior change approaches, very slightly heterogeneous approaches, and just building on what you shared with us right now, Geordie. So to looking to the future, there's a captive audience here of schisto specialists, but also perhaps more generally public health colleagues. What could the sector improve or do a little bit better to make the behavior change framework, programs, approaches a little bit more unified? The toolkit will be coming out, for example, in the foreseeable future few weeks. Can we all rally behind that, or what are some of the things that the sector can do?
Well, that's a good question. Well, the toolkit certainly will be an important resource. Secondly, as I said, it's important to look at the literature in general, look at the different experience within the Schisto sector, but broadly in the ISNTD sector. And I guess ultimately use the best you can these kind of opportunities in which the sector with different practitioners and different people are talking to each other, be more aware of what are the initiatives that are being conducted everywhere. And most importantly, don't just look at the presentation. If you find a project that is quite interesting and appeals to your heart, reach out to the people in charge. Sometimes you can be surprised how much people are willing to share their own understanding of the problem and their own experiences. When we receive an email about how did this work, I saw you talking here or there, can you expand a bit more on this particular thing? We have this country and this situation. Maybe there might be something we can learn from you. So don't be shy, if you can say it that way.
Yeah, I think that's exactly kind of what I was going to say, Carlos. Is I think that really there are some specific guide tools that I think are coming out in the future, but really sharing, I think people underestimate the level of knowledge and experience that they have in other programs, and that it's not quote unquote social behavior change, but there are so many good examples, and sharing those things, I think, just strengthens this sort of knowledge base that we have, and looking at other beyond NTDs, looking at other health sectors. I think that's the beautiful thing about social behavior change, is that it cuts across all of our wants, needs, desires, and how can we kind of pull from those that wide variety of programming.
And also, could more be done to perhaps integrate the voices of affected persons and communities at risk, to embed those voices more centrally in the programs? And if so, how could that be achieved more effectively?
I'll start. I think yes, absolutely. It was great to sort of see in Ulfat's presentation that it started out with, it was a human-centered design, approach, right? And I think I'm really glad to see that that's gotten quite a bit of traction in the last, 5 or 6 years, in terms of really designing, that the design of these programs are, it's human-centered. It's at the core. It's the people who are the target audience are also the designers themselves. So those voices are really, really critical to good programming.
Yeah, basically to second what Geordie said, one of the challenges we had, particularly for schistosomiasis, from my point of view, is that intervention for schistosomiasis started when there was already treatment available. So the kind of a drug-centered approach to dealing with the disease. Whereas, for example, in the history of HIV, actually there was no medicine, there was no treatment. The idea was to start with prevention. They have a wealth of knowledge in terms of how to do community prevention, community interventions, including beneficiaries and target audiences in the whole idea of promotion. We're getting into that stage in our sector. Again, we would benefit from looking at these experiences in order to ensure the integration of affected communities, in order to design these interventions. And as I mentioned, there is already kind of a group of projects working with this social environmental intervention model that are already trying to do so, building up on this wealth of literature and participatory approaches to community planning and community design and participatory monitoring. So look at those sources and hopefully scale up if everything works well over time.
That's such a good point. Thank you. There's a few more resources being posted in the chat. Lots of information on the Global Schistosomiasis Alliance, the GSA's own website at eliminateschisto.org, with some behavior change tools there. Also, a really good article suggested here by Lydia Tripler, which has a whole section on snail control in Zanzibar and Pemba, and there's also a section on behavior change and one on MDA in Zanzibar. So a really great article there to answer some of the questions that came up earlier in the chat. Well, you've given us a lot of food for thought in this session, Geordie and Carlos, and also Ulfat with her really vibrant and interesting insight into what's going on in terms of interventions right in field. So I think to round off this session, all that's left to do is to give you a round of applause, which I'm sure the audience will join in with, and also another very, very big thank you. We look forward to seeing the next steps, whether that be in terms of the guide or the programs at Unlimit Health, and also maybe looking at further research and publications, plugging those knowledge gaps that you so clearly outlined for us, Carlos. So I'm sure the audience will join me in giving you a very big thank you. Thank you to all who tuned in live and joined this session. And we look forward to meeting very soon again, albeit online, for further schistosomiasis webinars with the GSA that I also thank very warmly. Brianna Furch is giving you a round of applause. And so on that note, goodbye and keep safe until we meet soon again. And thank you so much.
Bye, everybody. Thank you.
Thank you to all. All the best.